Thank you very much, Dr. Shub. I'm going to introduce the next two items on our agenda now. Get the lovely opportunity to bring my mother back up on stage. Professor Ben, that's almost two words you won't hear anywhere working with her. Her colleagues, her patients, her team that works around her, we're all on a first name basis. Even her kids, yes, it's not mother, it's Carol. Carol's been at the forefront of breast health in this country for the last 20 years. Some of her most renowned and lasting legacies are setting up the breast health centers at the Baragwanath Hospital, up the road here at the Helen Joseph Hospital, which is one of the largest of its kind that you'll find anywhere in the world, as well as the center we're at now, the Breast Care Center of Excellence, which is one of the first internationally accredited units in the world. She is incredibly busy all the time. Anyone who works with her knows she has this amazing ability to just pull energy out of nowhere. Good example of seeing that is directly after speaking to you now, she's going to run down to theatre and perform a live surgery for us that we will show in this workshop. So without any further ado, here's Professor Carol Ben, my mother.
So I thoroughly enjoyed that talk, Peter, because I think the thing is, I always say, I've ordered my boat and Barnes making my granny flat, because I think that the future of surgery is really going to change. And I think the thing about radiology is once you can tell me which cells are alive, dead, normal or abnormal, combinations with things like cryosurgery, combinations with things like ROT, Vikash, the combinations of doing those oncotypes on the core biopsies before we even operate, and the changes that we're seeing in oncology, we're going to be saving many more breasts and many more people from what I always say is technically an old-fashioned slash and burn. Okay, so I'm going to talk about the evolution of sentinel lymph nodes. Sarah Neitz, who runs the Joburg unit, I'm very pleased you're here. I have to say, if you want good reading, one of the nicest readings comes from South Africa, and that is you and Jenny's article on sentinels post-neoadjuvant chemo. So well done. Okay. Needs to have more hits on it. It always distresses me. Okay, go. Let's go. Where am I going? That one. Okay. So the past is the axilla. It is an old-fashioned dinosaur. The axillary lymph node dissection is something of the past. And I think what we need to know is it causes morbidity, that there are a range of problems when we do sentinel lymph node biopsies. And I think you must all look at the different guidelines because we've changed from, I remember training and doing 25 nodes to then 14 nodes to now 7 nodes. So where were we before these trials? Amaris, Z11, 32, 2301. The axilla must be staged for prognosis, and one must remove all the lymph nodes, particularly if there's disease. It's practice, but was it safe to actually do a sentinel in node negatives? The NCC and ASCO guidelines said that we mandated axillary lymph node dissections. Sentinel was positive, including micromets and ITCs. And I'm going to ask you, do you think this is true or false? There were small reports, only small reports to say no axillary lymph node dissection. If not, they spoke about high rates of recurrence. And I want to know, what is your definition of an axillary lymph node dissection and how you do it? So do you believe in the importance of the axilla today? Do you still think it's the most important factor predicting prognosis? And how do you think about your clinical assessment and your imaging modalities? Surgical removal, histopath examination, what are you doing? H&E, ITCs, and is this the only way to stage the axilla? What is safe oncology care today? Okay, and is it standard of care in a clinical and ultrasound node negative axilla to do a sentinel? The most important thing for me is breast cancer is a systemic disease. Historically, it's a real boy thing, you know. Size more important than personality. Okay, so now it's about biology. Biology dictates cancer outcome, and I think we need to accept that. So if we go to infinity and beyond about the axilla, know your definition, first regional lodes. It's always interesting for me when I look at the studies. I think what people say, I took a sentinel lymph node, and how many nodes they took. And in some of the studies, when you analyze them, they've taken 7 glands, and they call that a sentinel. So it's very interesting to see. So answer these, okay. Sentinel lymph node as a sole tumor-bearing node occurs in up to 60% of women if you've got an ultrasound node negative axilla. and in 90% of patients with only harboring micrometastatic disease. So how do you feel about a sentinel and a 3-node sampling? Are you still doing a metastatic workup on an ultrasound node negative axilla and a CA153 in all your patients prior to treatment? Who should not get a sentinel today? Okay, node positive axillas. Who should not get an axillary lymph node dissection? What is your feeling on the node negative axilla pre or post primary chemotherapy? So our radiology assessment, okay, there's no doubt. Clinical palpation, no value. Value of ultrasound, huge, depends on the hands of who's using it. Other modalities, PET, MRI, problem areas, patient obesity, big accessory breast tissue, silicone, fascinating to see. Leaked silicone ability to check up on your sentinels. You can do nicely with elastography here. Retroviral disease, you've got to watch, and my absolute bugbear, surgical biopsies. Still being done. Know your definitions. What's the difference between an isolated tumor cell, a micromet, and a macromet? And know what's the best path. I mean, I've just had one of the registrars look at the BioVision and ability to pick up sentinels. Basically, send it to the lab, cut into minus to 2 mm features, intraoperative pathology. You can do, we've tried everything, okay, but with your lobular carcinomas, et cetera, you're always going to land up with problems. Experience and expertise. It's all about Yoda. Okay, so learning curves, experience of the surgeon and expertise of individual surgeon makes all the difference. Okay, so it's very nice to read the BJA's 2013 National Training Program. Honestly, if you guys do not have exposure, we have really good government units where we have teaching specialists. More than happy, I'm sure Sarah is exactly the same, that if you're not doing it, please come into the unit. You need to do at least 20 cases to make sure you're proficient, whether you're using sienna and dye, isotope and blue dye, whatever. Experienced surgeon, tumor size and injection. Otherwise, you're going to land up with problem. I know that looks really sore. Okay, technical trends. I really like the article this year in terms of, and I think it's post the whole Sienna, the fact that really you don't need to map. Okay, I haven't mapped for years. There's certain cases that I map with an isotope scan. A lot of us use 2 modalities. Now let's quickly go through the trials. Okay, so as Dr. Zers, I think you must all know the NSABP32 trial. You must know about the fact that 10 years out, what the data is around this trial, the fact in terms of the accrual numbers were good, how they were randomized into Sentinel and ALND and Sentinel alone, and low recurrence rate, good 10-year overall disease-free survival, and interesting, the 10-year survival on the micromets, also stable disease. So talking about micromets, just to go into the NEJM 2011, where they spoke about the fact that micromets associated with higher local regional disease. So basically, they used the NSABP32 trial, and they found a decrease in overall and disease-free survival with micromets. They identified the micromets, and they felt that it wasn't clinically useful. So this, for me, is the gut. It's about biology of disease. So micromets in certain biological disease, you're treating for biology today. Young patients, big tumors, and at that stage, the publication showed double regional recurrence, not affecting overall and disease-free survival. So where to go? I quite like this, the Lancet Oncology 2301, and basically it looked at axillary dissection versus no dissection, and the 10-year data out, well, 9.7 years is out, and it really shows that there is, even with micrometastatic disease, it's not necessary to go back in these axillas. The disease-free survival and recurrence rates are low. And I put this study in because it shows biology so beautifully. When you look at bone marrow mets and isolated tumor cell mets in the Sentinel, and you do a comparison, and what you show is that actually 10-year follow-up, that there is no significant impact on overall survival. So really, it's biology of disease that's dictating how people do. So let's go to this wonderful study that people love to hate, okay, and that is the Z11 trial, and point out what we ask all the registrars about: how many patients were accrued, how many actually patients did they get in the trial, how did you break down the arms into 249, etc., and the fact that there was a 5% crossover rate. But what came out of the trial? What's important? Okay, it's important to go back to the concept of that only a quarter of your patients have additional axillary lymph node disease. and that not all sentinel positive patients develop clinically detectable recurrent disease, and that non-removal of involved nodes may not increase locoregional recurrence, and basically radiation is a value in sterilizing the axilla. I do think it's going to be interesting with our ROT and how we assess things going forward. So the fact of the matter is this changed practice, it changed the NCCN guidelines, and we decided based on this study, the well-defined subset population, which let me mention is not divided into luminal A and luminal B, ERPR positive disease, okay, small T1, T2 tumors, node negative clinically, did really well, 10-year out. Lovely trial, like the Amaros, don't know, better, Sarah, I don't know your feeling. And basically they took patients for mass or BCT, clinically node negative up to 5 centimeters, ERPR positive. And this is the abstract now from this year, showing that the 10-year recurrence is low, particularly with the patients treated with axillary radiation therapy. I want to just comment on the second primary, contralateral breast. I think it's interesting, but I don't think it's relevant in terms of how we see it. So we need to look and see what type of primaries and how they were initially assessed, because it's opposite breast. And it's a safe treatment in patients with tumor-positive sentinels. So what are the tribulations that you have to go for when you know and talk about sentinels? Let's talk about second primary drainage. Those patients who have new primaries, how are you assessing the sentinels? I think this is where your dual therapy, particularly with your isotopes, which we don't use a lot anymore, is of value. Because some of them drain to opposite axilla, some of them drain to internal mammary, some of them drain to different areas, and you've got to work out what the relevance. So they all should be discussed in a multidisciplinary environment, and you need to work out when and where you're harvesting and if it's of value. I mean, I've grown up in an era of harvesting internal mammary, so, okay. So should the procedure not alter the management, ask yourself why you're doing it. This is a intramammary sentinel, and I'm just bringing it up just because of the concept of that now this is node positive disease, so it may affect in terms of how you decide to radiate, and that's what you need to know. Clearly there's no margin issue, it's a node, okay, there's no margin issue anywhere anymore, but issues such as chemotherapy and radiation are important, okay. So in terms of primary chemotherapy, so the value of doing a sentinel, in my opinion, pre-primary chemotherapy is very, very small. It's a very small subset of patients. So the axilla is downstage in 25% of the cases. What I'm interested in, the low KI luminal Bs, oncotyping them up front to technically look that they're behaving like luminal As, knowing what's going on in the axilla and using just localized ROT. That's my interest hugely here. So the axilla is downstage 25% of the time, and you need to know that you must document carefully and as best radiologically as possible, not clinically, upfront in your MDT, what your pre-chemo staging is, particularly around radiation. I always say that the radiation oncologists are the poor cousins. We forget about them, and then we start arguing who needs what later. Okay. The Sentina trial, 4 different arms. I mean, if you can nitpick any trial. So there are issues around this trial that you can really pull apart, okay? But you've got to take what's important out of it. So if you take the patients who were node positive and move to node negative after neoadjuvant chemotherapy, what you need to know is that the false negative rate is higher than the accepted 10%. So I think for me, what we learn about it, because we sentinel post primary chemo, but we do it in 2 modalities. We take more than 3 glands, and we use dual techniques in picking up the glands. So the other issues is if the sentinel is free of disease, okay, post, for me this is the issue. Clinically node negative patients with a positive sentinel prior to neoadjuvant chemotherapy. When you try and do a second sentinel post chemo, your identified rate is way, way too low, and your false negative rate is way, way too high. But what do you learn from this? You learn that back to the axilla is inevitable if you've got a positive sentinel. And you need to learn that you've got to assess cost always. Cost of surgical morbidity, cost of knowledge of radiation treatment, and extent of radiation treatment. So there's a playoff. And I think that you have to discuss these patients individually in your multidisciplinary meeting. Decide what you do in your unit, okay? I think the one thing we learn is there's no 100% right and 100% wrong. And it's only by putting it out there and determining what you're going to choose to do, that you can follow up your results. I was very pleased that we just got an abstract in for ESO last night on our mag seeds in the axilla. So this is a very, very small trial, small patients. I mean, false negative rate, we're slowly getting there, 12.6. But again, what do you learn? Okay, you learn that you must use dual traces and I think take more than 3 nodes. Okay, again, FNA positive nodal disease prior to primary chemotherapy, very, very small trial. I think dual traces, immunohistochemistry is interesting because I know Simon likes to do it around picking up your micromets, and you must look at all your mets. So I think we have forever changing guidelines. If I go back to 2011, we have a guideline that talks about sentinels prior to primary chemotherapy. We now have a situation, NCCN guidelines accept that sentinels pre and post primary chemotherapy in the clinically node negative axilla, with a caveat here in terms of number of nodes and what you're taking. So I think the race going forward for me, for all of us, is going to be the marking of the nodes in the node positive axilla. We mag seed us and how you're marking them and what you're taking. The concept of central sampling post neoadjuvant chemotherapy, how we're doing it, and the concept of a targeted axillary sampling. So I think most of us around are accruing patients to try and design and answer the question of how do we get accurate, minimal axillary dissection sampling, call it what you like, assessment of what's going on in the axilla post-primary chemotherapy. So challenges in DCIS. Okay, if you're doing mass and DTIs, sentinel your patients. If you've got lots of extensive high-grade HER2-positive disease, you can do a sentinel. The ones that, so I'm collecting a series on the papillary neoplasms, and the ones with DCIS always just bite you in the bum. So those ones, it's worthwhile to sentinel them. But most women do not require assessment or sentinels in breast conservation. And obviously, you've got to watch your caveats around who's getting radiation. Are you oncotyping your DCISs and assessing it from there, and extent of DCIS? So radiation and DCIS is a separate topic. We've got a specialist here. I think what we need to realize is sentinel lymph node biopsy, it's a tool. Okay, obviously we want to surgically still take out everything we can see, but you've got to ask yourself why. Breast cancer is a systemic disease. Okay, yes, there are aspects of breast cancer you can treat locally. The information gained by the sentinel may determine oncological treatments and orders, but for me the future is in genetic profiling on core biopsies in terms of who's going to get what oncological treatments. There's very little in our unit. We don't at all upfront sentinel around reconstructive procedures. In fact, we're going to have 2 very interesting case later, but we've got a very interesting series on radiating DTIs with the use of certain pharmacological agents that absolutely we're having very, very low rates of capsular contraction. And obviously important to determine radiation requirements. So a lot of us use, well, it's not even Sienna now. Okay. So this in terms of picking up, and the nice thing about it from a pathological point of view, if you want to know that you're accurate, you can actually see the tracer in the sentinel. It's very easy. Just ask your pathologist to say, are you seeing iron pigment picking up? And we presented 2 very nice papers in ESO last year around exactly this. You determine your accuracy by seeing the iron pigment in the sentinel. So in our practice, and when I say neoadjuvant chemotherapy, it's actually some form of neoadjuvant chemo or neoadjuvant therapy, let's put it better. Our locally advanced patients, obviously the most difficult to manage are locally advanced luminal A's. Basically, they get some form of neoadjuvant therapy. In our subset, in our young patients, big tumors, etc., we really place mag seeds. We want to know in the sentinel up front prior to treatment. Patients with poor tumor biology, post-primary chemo, they get a sentinel and 3-node sampling. In this unit, most of our HER2-enriched TRPNEGs, luminal B, obviously there's all exceptions that are node positive, are getting some form of neoadjuvant therapy with really good outcomes. I think Bernardo's just come back from ASCO with very good PCR outcomes. And we're doing a sentinel and probably a 3-node, 4-node sampling post-neoadjuvant chemo. So I've whizzed through sentinels. There's such a lot. You can talk forever. But any questions? Sarah, any comments? Okay, read their article. They've done our country proud. Okay. Anyone? Anything? No? Happy? No one still taking out 14 glands? No, please? Okay. 0 out of 14? No. Okay. Okay.
Carol, now, do you do sentinels in node-positive patients and then in
So are you talking post-neoadjuvant? Okay, so, well, post-neoadjuvant, we want to know that they're sonar, that they're node negative. Okay, well, ultrasound node negative. So in other words, if they've still got big chunky glands, absolutely we take out what the disease is, but we don't go. In fact, in a lot of our patients, sometimes we second line them if they've got bulk disease. We don't just go and say, hold on, let's cut because we can. I think if we're going the neoadjuvant route, we try and aim for clinical and ultrasound, no disease, okay? The hardest ones are the ones, the big luminal A's that are sitting with CAS between 10 and 15, and we often just whack them with weekly Taxol for a while. We can't seem to get on top of those. And I think that's a problem of our screening. So absolutely, if there's ultrasound node, yes, okay. But what we do is we use dual techniques, and we take out, technically we're taking out about 5 glands. So really, 7 is a dissection. We have a good feel and have a look, and our recurrence rate. So part of one of the paper presentations that we put in, just recently had a look, 20 years, 13,000 cancer patients, and loco-regional recurrence, and we've not done massive dissections, is unbelievably low. So you've got to ask yourself what you're doing. I mean, please, guys, comment and disagree and everything and say, Dennis. I am a continual competition with Peter around his ability to determine exactly what's going on in the glands on whatever technique he can. Yes?
I do have a question regarding your use of Maxine. I'm in favor of the wireless localization methods for identifying symptoms.
Yeah.
But there are pros and cons to various devices.
Absolutely.
One of the concerns that I have with Maxine
Yeah.
is the radiographic artifact that
Ah.
MRI.
It's-
How do you manage that in the workup of
It is a huge problem. So you're 100% right. So basically what we're about to trial out a new device through Sysmex. It's going to be a first here in the world that Peter's going to trial out to see if we can get no artifact on the mag seed. But I've tried the little ones with the antennae and this. They don't purchase the node properly when it fibros. So my best thing at the moment is nothing and dual technique, okay, but with a careful documentation up front and careful radiology prior to surgery, and all the mag seed. But the patients on the mag seed, what we're trying to work out is which patients we'll not need to MRI, because during the treatment, because that is really the future, is what determining response down to whatever oncology treatment. And I'll talk about oncology in a big, wide way. So it can be endocrine, it can be whatever. But the MRI at the moment is so good at determining that you've got effective treatment. So you've got to watch your timing on your placements of your seeds if you're going to place them in the axilla or how you're going to dock them. So I'm fully with you on it. So the ones we placed, again, I mean, you could have shown some lovely pictures of these massive areas of artifact around a mag seed. It is a problem. I fully get you on it. I think this is the race. How do we go forward with less is more in the axilla? What are we going to use? I've even looked at I got them to bring out the microbubbles, whether we put the microbubbles in, that might be of use. Put the microbubbles into the sentinel, and then I think Barron and myself used our little antennae device on the weekend. Nice, but quite finicky, and it doesn't purchase nicely, particularly into lymph nodes. Okay. Anything else? Anyone else? Good? Fine? Sarah, comments? No?
Just another comment.
Yeah.
I think the real thing that's coming is no surgery.
Absolutely.
So we're going to.
In fact, that's why I said I've got my boat, okay? The boat, the granny flat. I'll come in and visit. We won't need to operate. Between cryo, between RT, between radiology, immunotherapy and genetics, really. I'm happy to be the dinosaur, but I'm not retaining water, Barnes. Okay. Okay.